The one that got me on this topic after we had a patient that I was talking with about sleep hygiene, and he was hopeful that somebody would do a presentation on behavioral treatments. So it actually is a little serendipitous that he ends up presenting me today, because this was something that he had thought would be important to be presented on, and it's certainly a topic that, after getting into it, seems incredibly important, and one that I don't feel like we get a huge amount of education in. So nothing to disclose. I haven't been involved in this field long enough to really have anything to disclose. Clearly, I'm sending out job applications now, so at some point I might have something interesting here. My overall goal of this lecture is really to try to give everybody a bit of a utility belt, so to speak, for the treatments of insomnia. And so I'm going to be touching on several different approaches towards behavioral techniques, some alternative techniques. My main goal was just to avoid anything as far as an ingestible goes. So we're not going to be talking about melatonin, valerian root, anything like that. So I'm going to start off the presentation by talking a little bit about what sleep is, what contributes to sleep. But I'm going to zoom through this a little faster than I usually would, because we ended up having a very nice presentation on this 2 weeks ago by my colleague, Dr. Gilly. So sleep ultimately ends up being driven by two drives, our homeostatic drive and our circadian rhythm. The homeostatic drive we understand as basically being this issue where the longer we stay awake, the more tired we feel. And we don't understand the mechanism of this very well. We know adenosine has something to do with it, and it makes some sense when you start to think about caffeine, which is an adenosine antagonist, but we don't really understand this very well. What we do understand better are our circadian rhythms. Our circadian rhythms are mainly controlled by light, but have a lot of other things that lead into it, ultimately going into the suprachiasmatic nucleus, which ultimately regulates melatonin release, leading to changes in arousal. So for instance, when we're exposed to wavelengths between 400 and 500 nanometers, our eyes end up interpreting that, and it tells us it's daytime, it's time to be awake. And when we have that happen, we end up releasing less melatonin. Being in a dark environment generally helps people to sleep. So sleep is made up of several stages. We have our non-REM sleep through N1, N2, and N3. And then we have REM, or dreaming sleep. These stages frequently last about an hour to an hour and a half in length. And you can see here that we have an image that kind of shows a typical night's 8 hours of sleep just going through these stages. As far as this presentation goes, we're really focusing on the idea of the differences between N1 and N3 sleep. In N1 sleep, people are frequently laying in bed. They're somewhat aware of their surroundings. They feel like they're still awake. They're kind of in this drowsy state. While in N3, people are really out, and they're actually getting good quality sleep. And when we're talking about problems with insomnia, a lot of people spend huge amounts of time in N1 light sleep rather than in the N3 deeper slow wave sleep. So we want to try to be promoting people into these deeper levels of sleep where they're actually getting some benefit. So insomnia affects a lot of people. 30% of adults have problems, have at least some symptoms with insomnia. 10% end up having enough of this problem to cause daytime distress. 10% end up having enough of it that it's occurring chronically. And 45% of those with psychiatric diagnoses end up having this simultaneously. And on the alternative side of it, 20 to 40% of those, sorry, I said that incorrectly. 45% of those with insomnia will meet criteria for a psychiatric disorder, and 20 to 40% of those with a psychiatric diagnosis suffer from insomnia. So for those of us in the mental health field, this is something that we spend a lot of time dealing with. I'm going to kind of take a step back and talk about the DSM-5 diagnosis of primary insomnia, now called insomnia disorder. So this is insomnia which is not specifically due to another etiology. People will have difficulties with initiating sleep, maintaining sleep, or early morning awakenings with this. It has to cause distress or impairment. We're talking about disease, so it has to cause dis-ease, occurring for at least 3 nights a week, for at least 3 months. They have to have adequate opportunity for sleep. So if somebody has a newborn baby and they're not sleeping well, I mean, it's pretty obvious what the problem is. I wouldn't be speaking from experience there. And there has to be this as the primary etiology. So if somebody's using cocaine at night, I mean, it makes sense that the insomnia is probably being caused by their stimulant use. there are many other disorders which can actually be related to insomnia. DSM-5 right now has a whole set of diagnoses called sleep-wake disorders, and every single one of these is primarily a sleep disorder. So lots of things can be clued into this, and then multiple other psychiatric diagnoses occur as well, which end up having problems with this. And none of these come as any surprise to people within the mental health field other than personality disorders. And within one of the meta-analyses that I was reading, it was describing personality disorders as a cause, which I had never heard about. Ended up doing my own PubMed research on it, and in fact, there's quite a bit of evidence showing that borderline personality disorders are significantly associated with insomnia. A little bit less details on obsessive-compulsive personality disorder, as well as what were the other two? Sorry about that. As well as problems with avoidant personality disorders and schizoid personality disorders as having some evidence of being problematic in those disease states. Lots of causes of this. And when we're going to be talking about this mainly, we're going to be focusing more on primary insomnia because that's where most of the research is as far as behavioral techniques go. But I will mention specifically when there's moments where there's other disease states which have been shown to be effective as far as the treatments that we're talking about. Multiple medications can cause problems with insomnia. I'm just going to pick out on diuretics briefly on this because a lot of times people are being given diuretics at night. It's causing them to wake up multiple times in the evening, urinating, and so in that situation, that's a really good moment to specifically pull aside a primary care provider and to tell them that you want to be giving that at an earlier time in the day. But certainly something to be spending some time looking at when you get a patient that's having problems with sleep. Multiple recreational drugs can cause problems with insomnia. The first four are all of these stimulants that we're talking about, not a big surprise there. Alcohol's a little bit more interesting, though, because it can actually decrease N1 sleep and REM sleep during that first portion of the night. If we're talking about an 8-hour sleep cycle, people are generally sleeping better for those first 4 hours on alcohol. But after that, it actually causes a bit of a rebound effect where their N1 sleep and the REM sleep actually increases to the level that it completely negates any of that effect, any of that improved effect during those first 4 hours. Sadly, about 28% of people who have had problems with insomnia have at some time or other tried to use alcohol as a sleep aid. So it's really important to have this conversation with people about alcohol and it not really improving sleep, despite the fact that they feel that it does. Bunch of medical causes of this as well, so you want to make sure that people are being well treated, ordering TSHs on people. But why are we treating this? So talking about the consequences of sleep, there are many. This is only going to be like a very brief touch on it, but people are more likely to get into motor vehicle accidents. They're going to have decreased work productivity. They're going to be more likely to develop mood disorders from it. Frequently when we're talking about insomnia, we worry about people going into a manic phase if they're bipolar. We worry about people developing depression again. Interestingly, anxiety on the alternative end of the spectrum tends to drive insomnia more than insomnia driving it, but there's certainly some interplay there. And it can also be problematic in people with psychosis. Psychotic patients are more likely to stop using their medications, and they're more likely to have a relapse of psychotic symptoms if it's not being well treated. So incredibly important population to treat for their insomnia. Alcoholism is also a disorder which can be driven by insomnia to some extent. Again, about 28% of people have tried using alcohol for sleep, and alcoholics are more likely to relapse if they're not sleeping well. In all populations, there's an increased emotional dysregulation as can be caused by insomnia. This is particularly important in patients with PTSD, and there's quite a bit of research right now talking about approaches towards trying to touch on the sleep problems in PTSD prior to anything else, just because they can't really engage in therapy as well if they're emotionally dysregulated. So certainly important. Tons of other problems. Increased all-cause mortality in men, increased cardiovascular mortality in men. Ultimately, there's just not enough research out there on women to look at this, but I suspect that it's a problem in women as well. It can lead into hypertension, diabetes. I didn't end up listing this because there's some controversy there, but there's some question about it causing an increased risk of suicidality as well. So lots of problems with it. So with all this going on, why are we not just going to talk about drugs? Because this is problematic. We need to get these people fixed. Well, If we're talking about GABAergic agents, we all know that, that many of them are teratogenic. They can cause respiratory depression, excessive sedation, dangerous in people with renal or hepatic impairment, can cause poor decision making. So you don't want to be taking Ambien before you start your night call. You have an increased fall risk, can actually cause paradoxical agitation in the elderly, so it might not necessarily be the best approach in geriatric patients. Anything that's antihistaminic can cause weight gain. Many of these drugs can cause psychological or physical dependence, and all of them have drug-drug interactions at some level, shape, or form. So, it's important to do it. And, I'm a psychiatry resident, so I'm always thinking, well, why don't I just treat it with drugs? I mean, seriously, let's just throw a medication at it. We don't have to worry about, no, we're not going to do that today. We're going to talk about behavioral techniques. And the reason why is behavioral techniques are actually better, specifically than GABAergic agents for the treatment of insomnia. Cognitive behavioral therapy for insomnia has been shown to be better than a whole host of GABAergic agents, as have stimulus control and sleep restriction therapies. Even acupuncture has been shown to be better than a GABAergic drug by the name of astaxanthin for insomnia. And bizarrely, this was a surprise to me, but about 75% of patients actually prefer therapy over medications for the treatment of insomnia. That was based on a meta-analysis. And particularly women and younger adults prefer it. So as time progresses, I suspect that we'll actually spend more and more time trying to approach this from a behavioral standpoint. So finally getting into it to actually talk about some of these therapies. Sleep restriction therapy is an attempt at trying to improve that homeostatic sleep drive. So we're trying to get people to stay awake longer. The idea here is, again, to be decreasing the percentage of N1 sleep and to improve these broken sleep patterns, trying to consolidate that sleep, more N3 sleep, quality over quantity, right? So something you're going to notice within a lot of this is that we're talking about avoiding naps. And this is an underlying issue of trying to maintain a good homeostatic sleep rhythm. Because if you're taking a nap in the middle of the day, it's just going to basically ruin that buildup so that they can't sleep at night. Before we really dig into this entirely, naps at times are important. If somebody's feeling really exhausted and they're about to drive a car, they're about to operate heavy machinery, you don't want them killing themselves. You want to keep your patients alive to start off with. At moments, it's actually appropriate to take naps. That being said, it is one of the ground rules of sleep restriction therapy. When we're starting to bring people into this form of therapy, we want to be calculating how much time they're spending in bed and how much time they're spending asleep. So we end up ultimately calculating the sleep efficiency based on this by dividing the total sleep time over the time in bed. When we're trying to tell people when to fall asleep, when we're doing this form of behavioral treatment, we tell them to go to bed at the time that they're actually falling asleep. So if somebody's going to bed around 9 p.m. and they're falling asleep around 11 p.m., we have an understanding that they're probably a bit of a night owl, and we just want them to actually start going to bed at the time that they feel most comfortable, because they're most likely to actually just fall asleep naturally at that time. We're going to be talking about altering how much time people are sleeping on this, but at no point in time are we going to recommend that people are getting less than 5 hours of sleep. And a part of this is research-based, because it's been shown that most of the medical complications associated with insomnia happen when people are sleeping less than 6 hours a night. So it's approximate. But so this is an image of a typical sleep diary. And it has bedtime, rise time, the amount of time people are trying to fall asleep, number of awakenings, and the total time that they spend awake. Also looking at the substances that they're using, the naps that they're taking during the day. This sadly doesn't describe anything about stimulant use, but that's an important aspect of it. Talking about when they're drinking caffeinated beverages, when they're using nicotine, are incredibly important as far as how it's going to affect sleep. So we're going to go into an example of this so I can kind of explain how it works. So we've got this guy, Ignacio, and he's in bed from 9 p.m. to 5 a.m. It takes him 2 hours to fall asleep, but then he sleeps well past that. His total sleep time then is going to be 8 hours. His total sleep time is going to be 6 hours. Total in bed time is going to be 8 hours. And then 6 over 8 is 75%. So that's his sleep efficiency. Bedtime should really be 11 p.m. because that's when he's naturally falling asleep. So we're going to talk to Ignacio every 2 weeks. And we're going to try to calculate his sleep efficiency every time utilizing that sleep journal. So if his sleep efficiency is greater than 90%, then we're going to actually push his bedtime back by about 15 to 30 minutes. So we're going to tell him, okay, you're sleeping more efficiently at this point. Now I want you to be going to bed instead of at 11 p.m. at 10:30 p.m. If his sleep efficiency is still 85 to 90%, we're not actually going to change the way that he's sleeping at all. And then if he's sleeping for less than 85%, we're actually going to pull back his sleep by another 30 minutes and tell him to go to bed at like at 11:30 in that case, because he's still not sleeping efficiently. This number is different for the elderly because they end up sleeping less naturally, but in general, these are the numbers that we end up working with. But there are alternative approaches towards sleep restriction therapy. One of the approaches is looking at specifically making sure people are falling asleep in 30 minutes or less. And then based on how often they're actually doing that, you alternate either increasing the sleep by 30 minutes or decreasing the sleep by 30 minutes. And then there's another one, which I want to focus on briefly, called the Sleep Need Questionnaire. And this is based on Arthur Spielman's research, who's kind of a luminary in cognitive behavioral therapy for insomnia. This ends up using both the sleep efficiency that we were talking about, so total sleep time over total in bedtime, but also uses this questionnaire to figure out how well they're functioning during the day. So you ask about them feeling tired or fatigued, feeling sleepy or drowsy, taking naps, and feeling like they're actually getting enough quality sleep. You end up using a score based on that on top of the efficiency to determine how much you're actually going to alter the sleep, that 15 to 30 minute thing that I was talking about. But this is getting a little bit more complicated. Obviously, many clinicians are going to probably prefer just doing something a little bit more simplified than this. But incredibly important when we're getting into cognitive behavioral therapy for insomnia. So the evidence for sleep restriction therapy is pretty good. It's been shown to improve sleep on average by about 33 minutes in one of the meta-analyses, and can actually improve sleep efficiency very much so, from 67 to 87%. It's been shown to be effective in elderly populations, and again, preferable over GABAergic sedatives over time for insomnia. There are contraindications to this. Clearly, again, we're telling people not to nap. We're trying to force people to become a little sleep deprived. So if somebody's a nurse anesthetist, you don't really want them falling asleep in the middle of their work. People with a history of epilepsy, parasomnias, breathing disorders, or bipolar disorder are all at risk of worsening conditions if we end up causing insomnia to become worse over a short period of time. So it's a relative contraindication to avoid treating those patients with this form of treatment. And while we're focusing on this, we're looking a lot at bedtimes. We're not focusing a lot on waking up. So people who are primarily having problems with early morning awakenings are generally not helped by this form of treatment. So moving on to another form of treatment, stimulus control therapy. And this is an approach towards working on reinforcement by cues. So we're looking at the Pavlovian dog effects with this. If somebody perceives their bed as being a place where they fall asleep easily, then they will fall asleep easily in bed. If somebody ends up developing anxiety regarding falling asleep, then the moment that they hit that bed, they're just going to start worrying. So we're going to try to reinforce the bed as a place where people sleep effectively. So again, the rule of no naps. You're going to recommend to patients that they are only going to bed when they're sleepy. So if they feel tired, go to bed. If you don't feel tired, stay up a little bit longer. You want to convince them that their bedroom should only be used for two things, which are sleep and sex. You have to very specifically remind people not to read in bed, not to watch television in bed, not to play Dungeons and Dragons in bed. I mean, you name it. People do all sorts of things in bed, but you really want to reinforce the idea that they need to be using it for sleep or sex and nothing else. You only want them to be laying in bed for about 10 minutes prior to falling asleep with this technique. And there are alternative approaches which talk about 20 minutes or 30 minutes, but based on most of the research, it was pushing towards only staying in bed 10 minutes. If they can't fall asleep after that time frame, you tell them, all right, get up a little bit, do something low energy. I want you to read a book, do something like that. But I don't want you to be watching television, going for a jog, smoking cigarettes. Sadly, you have to remind them not to do that. But trying to do something low energy and wait until they start feeling sleepy again, and then try to reinitiate sleep. You also want them to have a regular wake-up time, and that issue is trying to, again, get into this whole issue of maintaining circadian rhythms. So frequently, this isn't used as a form of therapy alone. It's used as a component in other types of therapy. So cognitive behavioral therapy for insomnia it's frequently used in. although alone it has shown to improve sleep onset latency. So that's the amount of time it takes people to fall asleep. It can also help people with sleep maintenance, so that's decreased early morning awakenings and decreased problems with broken sleep, multiple awakenings throughout the night. Contraindicated in people who can't get out of bed, so if somebody ends up having problems, if somebody's elderly and they have a gait issue, it would be a patient that you would recommend against this in, unless they have somebody to kind of help them wake up multiple times throughout the evening, which sounds like a difficult job. It's been shown to be ineffective in people with cognitive disorders and in nursing homes as well, so those are probably not the best populations for it. So moving on to what I had been asked to talk about in this lecture to start off with is sleep hygiene. And this is basically a set of multiple rules that can be effective towards trying to improve insomnia. Although the sad thing is counseling people on this alone and not using any form of therapy for it has been shown to be pretty ineffective. And on another level of this, if you look at people who have good sleep hygiene versus poor sleep hygiene, they basically have very similar sleep patterns in general. So there's a lot of question that focusing on this alone is probably ineffective. And I'm going to bring you through my whole list of laws for sleep hygiene. I'm always starting these off with no naps. It's recommended that people get daily exercise. Generally, you don't want to be doing this 4 to 5 hours prior to bed because you can end up getting a little bit of adrenaline going that can actually make it difficult to fall asleep. But earlier on in the day, it can help to wear you out, help to make you fall asleep. There's some recommendation of trying to move from like a hot environment into a cool environment because that can help with your circadian rhythms. And a lot of patients try to take baths or showers prior to bedtime to help to work on this. There's a recommendation to try to get a light carbohydrate snack in an hour prior to bed to prevent people's blood sugars from dropping in the middle of the night, which can actually cause multiple awakenings. Of course, if somebody's eating a large snack prior to bed, it can cause reflux, so you want to keep it light. There's a recommendation to try to avoid drinking a huge amount of liquids prior to bed because you're going to be waking up multiple times in the evening to urinate. The avoidance of all stimulants in general is important. Caffeine, the main recommendation is about 6 hours prior to bed, has a half-life about, caffeine itself has a half-life of about 4 hours, so it makes sense to try to be pushing it back a little further than that. We already talked a little bit about alcohol. And the last one's kind of a complicated issue, creating a comfortable sleep environment, because people need to have comfortable bedding. Lower temperatures can help people to fall asleep. Being in a low light environment is important. Again, we want to be avoiding those blue lights at night. Avoiding screens is important because most of the screens that we have produce huge amounts of blue light wavelengths. We want people to be in a quiet environment, so using noise machines, earplugs, something like that. And a lot of people co-sleep with pets, and this is miserable. I mean, your dog is just going to be rolling over you in the middle of the night, waking you up. So something to recommend people doing is getting rid of that dog in the bedroom. I'm going to touch on a few of these issues because if you can actually convince people to do these things, it can help with sleep. The problem, again, is that you really need to be following up with people in regards to this for there to be any form of benefit. So it's been shown that moderate intensity exercise for 30 to 40 minutes, 4 to 5 times a week, improves sleep significantly. It can improve both sleep quality and sleep duration by 42 minutes on average. Tai Chi has also been shown to be very effective for this as a form of exercise. And this is a Chinese martial art which utilizes some forms of meditation as well. And doing that for 60 minutes, 3 times a week can improve sleep quality, decrease daytime sleepiness, and improve total sleep time by 52 minutes on average. And this is a group of people practicing Tai Chi. While we were talking about trying to cut back on caffeine use, it's probably better just to cut it out entirely. In a set of nursing studies, they had shown that cutting it out entirely can improve quality of sleep, sleep onset, sleep duration. So this whole conversation about just making sure you're not taking it 6 hours prior to bed is probably not a strong enough statement. Really cut it out entirely. It's a difficult thing to do. I know I would have a hard time giving up on coffee, but something that you can certainly counsel patients regarding. This is an adorable little girl wearing a weighted blanket. And weighted blankets are this form of bedding that have either metal chains in them or are weighted in some other form. And they've been shown to assist certain populations with insomnia. This was based on this concept that deep pressure can actually help to relax certain populations. These blankets are generally greater than 10% of your body weight, so you really need to have something pretty heavy to be effective for this. Not a lot of research on this right now, but there was one industry-funded study by big weighted blanket companies, which ended up showing improvement in sleep in adults with insomnia. Sadly, the pediatric studies only showed qualitative improvement and no quantitative improvement. So certainly something that's a reasonable approach. This is absolutely my favorite picture from any of the slide. This is Abraham Lincoln wearing some blue blocking sunglasses. We had talked a little bit about the idea of blue lights and their effect on our circadian rhythm. So there's a form of treatment which is called dark therapy. And dark is kind of an interesting term in this situation because dark therapy can be somebody in a room solely with red lights. It can be somebody wearing sunglasses that just block out blue light, or it can actually just be the dark. Generally, this is enforced from 6 p.m. to 8 a.m. to try to enhance circadian rhythms. Although in populations where we're talking about like shift workers, you're going to have to change this up to try to just get them an improved sleep period to try to stimulate a nighttime environment. Dark therapy has a lot of research behind it. It's been shown to be effective in rapid cycling bipolar patients to treat insomnia, as well as to pull them out of manic periods more readily. Can help people to sleep better if they're using screens at night. And in fact, the market's kind of already caught up with the science. There's a program that's called Efflux, which is entirely free, which can help to prevent blue lights being sent off by your computer at night. And even the new iPhones have an app for this. I believe Androids do as well, to try to decrease the amount of blue light being sent off. So very easy thing for patients to do if they're using their phones in bed at night, because I'll admit I do this all the time myself. It's been shown to improve sleep in postpartum depression patients and to actually improve the speed of their recovery from depression. Very effective in sleep in shift workers with some significant measures there. And people with just insomnia in general seem to benefit from this. So I'm going to step away from dark therapy to the most obvious second thing, which is light therapy. This isn't a form of sleep hygiene treatment, but certainly fits in with this conversation. So classically, light therapy has been used to treat seasonal affective disorder. It's putting somebody in front of a light which is at least 3,000 lux in strength for 45 minutes in the morning. And this can help to basically create a more appropriate circadian rhythm, which can in turn help with depression, can help with insomnia. It's been shown to improve total sleep time, mean sleep latency, mean number of awakenings, and can actually improve sleep by about an hour total. I've never seen it used alongside of dark therapy in any research, but I think that that would be a very interesting line of thought to actually get into, to try to create like these kind of perfect night and daytime cycles. So I'm also going to touch a little on relaxation, and there's a lot of different approaches that can be effective for relaxation. Guided imagery is one that is not effective alone, but this is basically an attempt at trying to get people to go to a calm, relaxed place. So go to your peaceful meadow with mourning doves flying above your head. It's used frequently in combination with other forms of relaxation therapy, but alone, not all that effective. One that it is used with is progressive muscle relaxation. And basically within this technique, you're going to be advising people to work on improving their somatic tone. And you do this by having them tense up their feet really tight for 5 to 15 seconds, then relax for 20 to 25 seconds, engage in deep breathing, go to that calm place, and then they'll work this up through their body, into their calves, into their hips, et cetera, trying to basically calm themselves down. There's two other techniques that are similar to this. There's Autogenic Training, which works on focusing on abdominal warmth, heart rate, head coolness, respirations, or heaviness of limbs, and this can also help to relax patients. And biofeedback, which actually uses some form of visual or auditory feedback, either in the form of like a graph showing where your heart rate is, or sounds showing where your heart rate is, or showing how tense the muscles in your forehead are. And that's the most common one. These frontalis electromyographs end up being used to try to show how tense people's heads are. And people can calm down by using this. Hypnosis has also been shown to be effective as a form of relaxation. And all of these are generally shown to be pretty much equivalent, which would bring me to the question of why not just use progressive muscle relaxation. It's easy to teach. It doesn't require a huge amount of background, and you don't have to be setting up EMGs on people's foreheads to teach them how to do this. Been shown to improve sleep quality, can improve sleep onset latency by 20 to 30 minutes, and can improve total sleep time, so very useful. Touching on a few other approaches towards relaxation, music therapy. And this one's kind of funny because it doesn't matter what type of music people are listening to. If you listen to music for 20 to 60 minutes a day, it can be death metal, it can be Purcell, it doesn't really matter. It can help you to fall asleep later on in the day. This has only been shown to be effective for sleep quality, though, and again, most of these quantitative approaches have not been shown to be very effective for it. But just telling people to listen to music once a day could be effective. Aromatherapy. So only one set of studies on this were looking at lavender oil, and it was lavender oil versus almond oil. So unless almond oil is some form of stimulant that we don't know about, lavender oil put into any form of aromatherapy can actually help you to sleep through the night. This has only been shown to be qualitatively effective. The quantitative measures, again, are not all that great. Yoga. So this is a gal doing a pose called Viparita Karini, and I probably just mangled that massively. But it's a pose which can be used to try to help with insomnia. It alone has been shown to not be particularly effective. It showed improvements in insomnia, but it wasn't statistically viable. Has been shown to be effective for some other things, though. Working through more poses than this alone have been shown to actually improve sleep quality for cancer patients. It's been shown to be equivalent to any of those other techniques that we had talked about with progressive muscle relaxation, biofeedback, autogenic training, or hypnosis as an approach towards insomnia. It does have some contraindications, particularly in patients with severe hypertension, pregnant patients, patients with glaucoma, back or spine issues. So anytime that you're going to be worrying about people as far as being physically active, this is something that you might want to be a little careful about using. Mindfulness meditation. So this is more than just relaxation, but certainly can be effective towards trying to treat insomnia as well. With mindfulness meditation, the underlying concept is basically trying to get to a point with one's thoughts where you're looking at things from a non-judgmental standpoint. And a portion of this is the meditation techniques. Some of the thought processes that get worked through within group therapy for this would be talking about beginner's mind, so approaching every night as if it's a new night, recognizing that you need to try different techniques to try to improve your insomnia. Trying to do the same thing over and over again, it just doesn't make sense. Working towards non-striving, recognizing that getting anxious about not having an ideal night's worth of sleep is actually going to make your sleep worse and not better. Working towards letting go, trying to recognize again that sleep is not a forced process, so you just kind of need to let it be. Working towards a non-judgmental approach, so the idea that thinking negatively about your sleep in any way, shape, or form is going to make it difficult to fall asleep. Accepting that when you're feeling awake that you're not feeling sleepy, and actually getting out of bed if you're not feeling sleepy. Working on trust, so trusting that your body is actually going to let you to fall asleep if you are feeling tired enough. And working on patience. Your sleep is not going to improve overnight. It's a process. So one technique towards this is these group therapy sessions. Those are usually began with a meditative session, then followed by didactics talking about sleep education, and then a group dialogue focusing on approaches that have been effective for people for sleep. It's been shown to actually improve sleep efficiency and total sleep time, which has been sustained even out to 12 months of treatment. It's sadly a little bit less effective than cognitive behavioral therapy. At 2 months, about equivalent at 5 months, but there are some underlying issues with sleep quality and dysfunctional sleep beliefs still in the population that's gone through mindfulness meditation approaches. Let me grab a sip of water before we hit this next one. Acupuncture. So acupuncture has several different approaches which have been shown to be somewhat effective for sleep. Sadly, most of this research hasn't been particularly great Every single one of the studies that was looked at in the meta-analysis that I got this from had made a statement that it had had difficulties with either lack of allocation concealment, they didn't discuss their blinding approaches, or they didn't discuss their intention to treat. So take this with a few grains of salt. Acupuncture itself is a is a form of Chinese medicine focusing on the flow of a life force, which is called qi, and people end up using acupuncture points to help to approach this. And many different techniques exist for this. Needle acupuncture, electroacupuncture, which is like an electrified needle, acupressure, which is literally just pressing on the points, or magnetic acupressure, which ends up using magnets at these points. And then there's also these approaches that specifically use the ear. And all of these have been shown in some way, shape, or form to be somewhat effective for insomnia. But sadly, most of the research looking beyond primary insomnia, so looking at insomnia caused by major depressive disorder, looking at insomnia caused by menopause, can actually cause problems with its effect. So good for primary insomnia, probably not for other approaches. More research is ultimately needed. Moving on to the big head honcho when we're talking about sleep treatments, cognitive behavioral therapy. So this is ultimately a combined form of therapy, which are ultimately preferable over these singular therapies that we've been talking about. I'm going to be pulling everything into this. It's been shown in research that a combination of both stimulus control and sleep restriction therapies are preferable to either alone. 29.6% of people end up having remission from insomnia with stimulus control therapy alone. 22.7% go into remission from sleep restriction therapy, but 43.9% of people ultimately end up having improvement if they use both together. So getting into CBTI, this is all based on Arthur Spielman's research. I mentioned him a little bit earlier, but ultimately he looks at these ideas of predisposing factors, and that would be something like a family history of major depressive disorder, precipitating events, so the stresses of the day, and then perpetuating mechanisms, which would be ultimately developing like a phobia for insomnia, because a phobia regarding sleep because you're continuing to have trouble falling asleep. Whenever we're talking about CBT, we got to talk about the ABCs. So you're thinking about people having an activating event, which in insomnia would frequently be trouble falling asleep. You're going to talk about a belief that occurs resultant from that. So if I don't sleep, bad things will happen. And then the consequence of that is then to develop a problem with anxiety surrounding sleep. And anybody who's frightened of clowns should close their eyes. This would be a clear form of sleep phobia. So motivational enhancement in CBT, some approaches that get used with it to try to make sure things are working well would be to express empathy, develop a discrepancy between where patients are and where you want them to be, well, actually where they want themselves to be, trying to avoid direct arguments, rolling with resistance, and ultimately supporting self-efficacy via approaches including Socratic reasoning, ABCs of CBT, etc. This would be more of a supportive approach towards insomnia. So CBT comes in multiple forms: individual, group, brief individual, self-help, telehealth. All of these methods have been shown to be effective for the treatments of insomnia. I'm going to focus on the Veteran Administration's manual for this, just because I wanted to give some idea of what these approaches would look like. Session 1, and this is a 6-session method, but in session 1, you're going to be basically trying to analyze the patient, get an understanding of what's the underlying problem. You're going to do a stop questionnaire, which helps to rule out obstructive sleep apnea, check for restless leg syndrome, try to determine if they're a morning or night person with an eveningness-morningness questionnaire, try to get an idea of negative underlying schemas using a dysfunctional beliefs about sleep questionnaire. You're going to do just a general assessment, make sure that you're actually developing some goals with the patients towards their insomnia, teach them how to use a sleep diary, and then you're going to use an insomnia severity index. And this ends up getting repeated at every single session to try to figure out how well they're sleeping to determine if their insomnia is still clinically significant on a period-by-period basis. So the general assessment ends up kind of looking at all of these things that we've been talking about as possible etiologies of insomnia during the beginning of the lecture, but basically just trying to get an understanding of what's leading into their insomnia, how you can try to actually alter things based on sleep hygiene. Second session, ends up being a period where you're reviewing their sleep journal. You end up repeating that insomnia severity index. You're going to provide sleep education, talking about sleep hygiene, circadian versus homeostatic sleep drives, and again, trying to teach them about disorders that they might have that may be contributing to their insomnia. You're also going to start using stimulus control therapy, which we had discussed earlier, as well as sleep restriction therapy. The next 3 sessions are entirely spent utilizing their total in bed time to alter their how much time they're actually spending in bed using sleep restriction therapy. And we're going to be using that sleep need questionnaire that we had talked about earlier as an approach for this, because that's what CBT uses. You're also going to be introducing relaxation therapy if needed, and utilizing the cognitive approaches that we have been talking a little bit about. Last session rounds off with continuing to work on sleep restriction therapy and making sure that they're being compliant with stimulus control therapy, and to work on a continued care plan. And this might include future sessions with that therapist, making sure that they're having follow-up for a sleep study if they have obstructive sleep apnea, and also talking about the risk of relapse, because people are always going to have periods of time where their insomnia is worse than others. And you want to convince people that they shouldn't just give up on these approaches that you've talked about if their insomnia gets worse. Insomnia can be cyclical. Tons of evidence for this. It's been shown to cause improvement in sleep quality, total sleep time via both actigraphy and polysomnography at 24 months. It can be used for pretty much any cause of insomnia at this point. It's been shown to be effective for patients with bipolar disorder, schizophrenia, people with underlying medical issues do well with this. It's been shown to be effective in the elderly, and can actually even be used to try to taper people off of benzodiazepines more quickly if they've been using them for sleep, because many people end up having relapses and needing benzodiazepines. It's just, they become really caught up in it. They become dependent with it. So it's an effective method at trying to taper people off of benzos if you're worried about their health on them. There's some other approaches towards CBT that are also effective other than this 6 sessions. Their brief methods have been shown to be effective. Ultimately, anything more than 4 sessions can actually be effective for trying to treat insomnia in this population using these techniques. And again, group therapy versus individual therapy versus brief individual therapy, all are about the same for outcomes at 6 months. Telehealth has been shown to be effective for insomnia as well. And even just trying to get people self-help books on this or little booklets can improve sleep, although it's not been shown to be as effective as engaging on one-on-one therapy, group therapy, or any of these other techniques. But certainly something that would be very useful if we ended up having access to these booklets within clinics just to try to get people to work on it on their own. This is a really bizarre form of treatment for insomnia. You actually need to have a lab for it. You bring people in, and you place an EEG on their head, and you're ultimately trying to give them feedback about how well they're sleeping through the night. Most patients with insomnia don't really have a very good idea of when they're sleeping, when they're not, and having some understanding of this alone can actually help them with sleep. This also ends up using typically stimulus control therapy as well as sleep restriction therapy to ultimately help people with their insomnia in the process. So the process for this is that you end up getting a sleep diary for 2 weeks, telling that patient to avoid caffeine and naps for 24 hours prior to their lab time, and you only want them to be in bed for 5 hours the night prior. You ultimately end up using Stanford Sleepiness Scale to assess them for insomnia. And this is the line that they say every single time that they let somebody go through one of these sleep periods. And it gets repeated a total of 49, 50 times. I think I would go really crazy hearing that over and over again. But trials ultimately begin at 10:30 p.m. In an environment that mimics their home as best as possible. So you want them to have the most comfortable pajamas, the most comfortable bedding, all of that stuff together. You place this EEG on them, and then they're given 20 minutes to sleep. During those 20 minutes, if at any time they enter a sleep stage for more than 3 minutes, the patient is woken up, and then they're allowed to fall back asleep. After the 20-minute time frame of those sleep periods, they're given feedback for 10 minutes about how well they were doing and how well they were sleeping. And in that process, they're also given this kind of break where they're watching DVDs, reading a book, doing something like that. And this goes on for a full 25 hours. They're then given 8 hours to sleep in bed after this because you want to try to counteract any of the insomnia that you've basically caused through that night. You then also end up monitoring their sleep diaries for 6 weeks after that to make sure that this patient's doing well. And again, this is frequently used in combination with stimulus control therapy because it's much more effective at causing relapses from insomnia in combination. Cool thing about this is the night after they end up going through this treatment, their sleep is already improved. It's been shown to improve sleep onset latency, total sleep time, and sleep efficiency immediately. Sadly, again, contraindicated in those who can't handle sleep deprivation, so not for the epileptics of the world, not for the bipolars of the world, etc. This one's fun, paradoxical intention therapy. So paradoxical approaches have gone on for over 100 years. The original approaches towards paradoxical treatments in general were for people with sexual dysfunctions, so look but don't touch, touch but don't touch genitalia, and over time they end up kind of trying to go towards the exact opposite end of the spectrum with this. It's ultimately an attempt at trying to help people with neurosis to basically counteract that, to break that cycle. And this starts frequently in sleep restriction therapy with a sleep normalcy questionnaire, and they'll end up answering this from the perspective as if they were somebody who slept well. And all of these questions, if you were somebody who slept well, you would say no to. So somebody who sleeps well wouldn't say that they're bad at sleeping. They wouldn't say that it's anxiety-provoking to go to bed. And in recognizing this, patients can start to understand, worrying about sleep is actually what's causing me to not sleep. Several methods exist for this. One approach would be with mellow patients telling them, sleep, it's no fun. Why don't you just go out and enjoy yourself? Take this as an opportunity to do everything that you've wanted to do with your life now that you're not sleeping well. There's a lot of catastrophes that could occur due to this, but just put those aside. You'll be fine. Or, sleep ain't, but nobody got time for that. So with less mellow patients, you're going to be telling them, keep your eyes open, just lay there in bed. If you start to feel sleepy, just keep your eyes open a little bit longer. Don't worry about you not falling asleep. Just lay there with your eyes open. Frequently, this is used in multi-component therapies and CBT. It has been shown to be effective alone in improvement in sleep onset latency. Although if you have people who are really concrete in their thought processes or have significant cognitive dysfunction, this is not a reasonable approach because they're actually going to listen to you and not sleep in those cases. I'm going to touch briefly on sleep compression therapy. This is an approach towards actually just trying to get people's total in-bed time to be equivalent to their total sleep time. Frequently useful in elderly patients who are just spending hours and hours and hours in bed, getting into those N1 sleep levels, not the N3. Generally only used in patients with little daytime impairment as well, because it doesn't make sense to be trying to just get them to be sleeping less if they're having impairment during the day. Generally, you just collect a sleep diary over 2 weeks, and then over 6-week sessions, you end up talking with them just to encourage them to try to get their total in-bed time to be equivalent to their total sleep time. And that would be the idea of this, that you don't want them to ever sleep in again. We don't have all that much time left, but there are some specific approaches which can be effective for nightmare treatment. I'm just going to touch on this first one because pretty much most of these end up working from a similar perspective. Image rehearsal therapy is used in people with PTSD. And in that process, you basically have people create a dialogue about their recurrent nightmares, and they end up altering that dialogue. So if somebody was getting shot at, they would end up having that gun shoot out confetti or marshmallows or something. And they change up every single component of this dream to have odd things occurring like that, which are more pleasant and decrease some of the anxiety surrounding those nightmares. And this, doing this for 10 to 20 minutes a day, typically prior to bedtime, can actually help to decrease the number of nightmares that they're having and can ultimately improve their sleep. Lucid dreaming therapy, sleep dynamic therapy, and exposure relaxation and rescripting therapy utilize very similar approaches. Self-exposure therapy and systematic desensitization therapy in people with nightmares are ultimately just looking at what's causing anxiety regarding those and helping people to confront that during the daytime to ultimately decrease the severity of that at night. There's several approaches which have been shown to be effective for sleep apnea, where the main problem is that people just don't want to be using their CPAPs mainly. Using exposure therapy to slowly get people with claustrophobia to try to get them used to the CPAP use is important. CBT has been shown to be effective for increasing CPAP adherence. trying to use like a tennis ball on somebody's back, an alarm system on somebody's back, or using some positional device to actually hold them in place to prevent them from being in a supine posture, which can cause worsening sleep apnea, can also be effective. Motivational enhancement techniques are also useful. And even learning to play the didgeridoo, which is this Aboriginal instrument, has been shown to be an effective treatment of sleep apnea. Very small study, but too interesting not to include here. Set of 25 patients over 4 months learned to play this instrument. And in that time frame, they had decreased sleepiness on their Epworth Sleepiness Scale, decreased apnea-hypopnea index, but no qualitative improvements. And so this man is clearly fighting sleep apnea. And so overall, multiple behavioral enhancements can be effective for treating insomnia. Sadly, focusing on sleep hygiene alone is not effective unless you're reinforcing this effectively with another form of therapy. And behavioral techniques in general seem to be more safe and effective than GABAergic drugs. And that about runs it. That's all about it. I'd just like to quickly thank Cynthia King, who is my mentor in this project. I'd like to thank Tracy Carroll and Reagan Gilly, who both helped me to get a few slides on this, on specific topics. Again, to Dr. Moore, who actually encouraged me to do this, and to my wife, who's had to listen to this presentation more times than I'm sure she feels comfortable. Any questions? Sorry for running a little late with that too, guys, with that late start.